Next speaker is Dr. William Hang. He is a graduate of the University of Illinois College of Dentistry and the University of Minnesota Orthodontic program, where he briefly taught orthodontics. All right. He then established a very traditional orthodontic practice in rural Vermont, and after 7 years, he became dissatisfied with the phases of traditional orthodontic approach, the traditional orthodontics approach produced, and embarked on a continuing education journey that ultimately took him to 50 states and 30 foreign countries. In the process, he moved to Southern California and developed a unique orthodontic practice with strong emphasis on facial aesthetics, achieved with innovative early treatment and adult treatment, but also became aware of the significant positive effect some of his treatments were having on airway positioning, okay? This opened up a whole new aspect of orthodontics, maximizing the airway for all orthodontic patients, and specifically treating patients with sleep disorder breathing or obstructive sleep apnea. Having been reopening previous extraction spaces since 1989, Dr. Hang recognized a syndrome he named extraction, retraction, regret syndrome. Say that 3 times quick, right? All right. Dr. Hang's approach to orthodontics is a result of blending the best ideas from the best practitioners and adding his own unique experiences. He has spoken on orthodontics, facial aesthetics, and airway locally, nationally, and internationally, and appeared on the British equivalent of 60 Minutes. He was a founding president of the North American Association of Facial Orthotropics, is a board member of the American Association of Physiologic Medicine and Dentistry, and is an advisor for the Academy of Oral Facial Myofunctional Therapy. All right? Please give a warm welcome to Dr. William Hang.
I'm happy to be here. People like to tell you in advance if they have any conflict of interest. I'm totally honest. That picture right there, I'm actually wearing the same tie. So just, there's nothing false, no false advertising here at all. I'm really happy to be anywhere, actually, because I grew up in Champaign-Urbana, Illinois, and I spent all my time there as a young kid going to the dentist and getting silver fillings put in. And I have had all those taken out, but I'm just happy to be alive because my brother and I used to, when he would be in the chair, in the dentist chair, and I'm not joking, I would be on the floor with a piece of paper collecting mercury off the floor, I'm not joking, and we would rub it on our Cub Scout or Boy Scout rings to make it shiny, and we liked that, so we wore those rings. So I'm just happy to be anywhere. So I want to share with you some of the things that I'm kind of passionate about. And breathing is incredibly important, and particularly here with the whole COVID thing going on. I've been told for some strange reason that what I have to say is controversial. I don't know why. I'm just a little Eagle Scout from Urbana, Illinois. But I want to warn you, so here's my warning. Be skeptical of everything I say and everything that every lecturer says. And to the degree that I can, we're going to have a lot of science in here, but there's not a lot of science in dentistry anyway. There's an article in 2006, one of the meta-analysis out there that says that 92% of what we do in dentistry has no reference in the refereed literature, and only 8% has reference in the refereed literature. But let's get right into it. This is a woman who has just had surgery 4 days earlier in St. Louis, Missouri, and that's what she says to, that's what she emailed me, or actually text message. She'd had teeth taken out, had had retractive orthodontics, and that's what she said after she's had surgery, which improved her airway. And that shows her airway, and you can see what she says. It feels so unbelievably good to breathe. My diaphragm moves, imagine that. I don't have to suck in the air, and I feel so calm. I will never, ever, ever be able to thank you all enough. You'll see her in a little bit, but I want to share another patient. This is what she has to say after we've reopened previous orthodontic extraction spaces, and you can see that she says her tongue fits into her mouth. She has lips again and renewed confidence. You'll see her case a little bit later. But this is just a way to help you understand the importance of breathing and how people feel about it. So this is a woman who was very deeply mistrustful of anybody, particularly me, because I was still an orthodontist, and it was an orthodontist who'd taken out 4 teeth for her, and she was not happy at all. You'll see her later. So it's not about me, it's about the process and the whole concept. and you developing teams. My best team member is my wife, and she's sitting back there. She's my best supporter. And we have a little hobby, building stone walls, and she gave me that excavator over there on my birthday 4 years ago, which is nice. You know you married the right woman when she buys an excavator for you. And I use the tractor, and we build these stone walls, and here's a stone wall, starting with one stone. And we make it go. There it is after a few days of work. And then here we're working a few days later. That's what it's like. And then a few weeks later, after the grass starts to grow in, it looks like that. But it takes a team to do this. And it's kind of like the team that's necessary to take a young man who's about 5 years of age in that picture on the left and turn it into that case on the right, where indeed the airway improves dramatically. Actually, this is a girl who we treated at about age 8, actually. But you can see the airway improvement on the right-hand side versus the left-hand side, something we do on kids under age 10. I'm not going to talk about that today, but we're going to talk about some other things. But many of the projects that we do in dentistry are a team effort. We can't all do it ourselves. So those are the stone walls at our place in Vermont. And it's like a project to take the girl on the left to turn into the girl on the right where the jaws are forward. It's not about aesthetics, though. In reality, it's about that airway. And I haven't seen everyone in this room yet, but I can guarantee you that not one person has an airway that is as big as that. And yet I would maintain that that's probably the airway that we were all meant to have. But we'll talk about why we don't have that and what that means. So for me in my life, airway isn't part of the problem, it's everything, and the rest is just details. So the American Dental Association, the most forward-thinking group in all of dentistry, comes up with a mandate here. Can you believe that? A mandate on anything, that we should all look for airway issues. That was 3 years ago. And so that's where we're at now, but has that really changed anything? I'd like for it to change everything, but that's why I'm here. So those of you who have been in dentistry as long as I have, I call this an acute lack of porcelain. This patient suffers from an acute lack of porcelain. But if we really look more deeply, we look at the face in this case, we see relative to this Bolton norm, which shows where the face, let's just put it this way, should be there, but most of us are far back from that. This patient has a sleep test done and comes up with the following. 454 abnormal respiratory events, and he ends up desaturating to 70% saturation. Now that's not a way to have a long life. But the point is, almost all those patients who have that severe wear already are dealing with sleep apnea issues, and then they're in all of our practices all the time. So what happens if you ignore the airway problems? Well, here's a woman, she doesn't have an airway problem, but it doesn't matter, because she was killed because she was unfortunately in Hoboken, New Jersey when that train came into the station and crashed and killed her. And this gentleman was driving the train, and you look at his teeth, and he's got a very narrow jaw with his teeth set back in his face, very likely had teeth taken out. He has a large neck, greater than a 17-inch diameter, places him at high risk for sleep apnea, and I guessed that, and was correct, confirmed by the New York Times article a few days later. So let's look at that and get right into the COVID thing right now. So here I start taking pictures of people off the internet that are dying this year from the COVID. And this is in early March, a gentleman from Michigan, a lawmaker, he dies. Look at his narrow jaw and large neck. The next one, somebody from the East Coast, a narrow jaw, died in his 50s. How about this one? The woman on the left doesn't die, but her husband, who's in his 32-year-old with a narrow jaw, and she's heavier, at more risk for sleep apnea, but I can tell you, I'd put my money on the fact that he has sleep apnea. He's been retracted massively. Or how about the 101-year-old woman who didn't die, born during the Spanish flu on a ship, survives cancer, survives the COVID, and here she is. She's got big, well-developed cheeks and a nice broad smile. Or how about the 100-year-old woman in New York State who, again, has a nice, broad smile and good cheek, well-developed cheeks, meaning her jaws are forward in her face, and likely her airway is bigger than most of the people that we deal with in our practices. Or how about this gentleman? This is a healthy teenager who dies. Just realize how healthy he is and think about it from what you know about health. And his mother, his adoptive mother, is a registered nurse and says, I can't tell you how a perfectly healthy 16-year-old boy can be making his own peanut butter sandwich late Wednesday night, and then the next day he's fighting for his life. So if this is a definition of health, then I have a problem with that. This gentleman is not healthy. And he was born prematurely at 25 weeks. Here he is, and this is his sister. They're fraternal twins. And Christian Guilleminault, who's the biggest name in sleep until he died a year ago in July, would tell you that every premature child will have sleep disordered breathing. So the point is, how can we define him as a healthy child? He's at great risk, and of course he died. It's very sad, but CNN thought he was healthy. So let's then get on to some stuff that we do. This is my typical life where I see a kid who's been told he needs to have 4 teeth taken out, and I say, no, we won't do that. But I refer him for myofunctional therapy and hope that he's going to learn to keep his lips together and breathe through his nose, because that's what we need. We need that because nitric oxide is secreted from the sinuses and kills bacteria and viruses, and that's in your nose. But if you mouth breathe, you bypass the first part of your immune system. So his whole face falls down and back, and he ends up looking like that. But if you look at his face, he's not that different than most other kids. The fact of the matter is, here's his mother, takes a picture of him on the couch, and he's snoring, which isn't okay. And now if we look at him, we see that his airway is significantly compromised and realize we didn't take any teeth out. This is a non-extraction case in our practice because all of them are. What would it have looked like if he'd had teeth taken out, had his teeth brought back in his face, and reduced his airway? And if we look, what does it really matter? You can go to the refereed literature. Ron Harper's got a zillion articles from UCLA talking about what happens to the brain in a child when they have oxygen saturation going down. It's not okay. The point is, it's not about teeth at all. If we go to the refereed literature, Dave Hatcher from Beam Readers has a great article. It talks about this is anybody with 52 square millimeters or less is at high risk for sleep apnea, and you can read it as well as I can. The point is, Christian Guilleminault even went to his grave saying he wished he'd never even come up with these classifications because they're meaningless. If the patient it doesn't sleep well, that's a problem. And all these are artificial constructs that we have in our profession that get in the way of what we're doing. Well, those of you would say, well, golly, why doesn't this kid just wear a CPAP for the rest of his life and he'll be fine? Well, let's look at the refereed literature and see what is said about that. This was 4 years ago in August from the New England Journal of Medicine. It says basically, what it says is, excuse me, I didn't say that. There's no statistical evidence that it's going to stop anyone from having a heart attack or stroke, which is basically why people wear the CPAP machine, is to try to, live longer. You feel better in the morning, but are you going to live longer? So let's look a little bit more from some of the big names in sleep. John Remmers, Harvard-trained guy. That's what he has to say. And look at that. 65 to 80% of stroke patients have apnea. 17%. Now these are facts and figures from several years ago. My bet is it's well over 20% by now. And 95% of those who have it are undiagnosed. 60 to 80% of snorers test positive. And if you don't get your sleep apnea treated, your ride here on planet Earth is 20% reduced. And everyone who snores will develop sleep apnea if they live long enough. Oh, that's very comforting, isn't it? And Remmers says that's the big deal. And this is the bottom line for those of us in dentistry. It would not exist if the jaws were placed properly forward in the face, like forward in that direction. Big deal, given the fact that all of our faces are down and back from where they should have been. And there's a ton of evidence in the literature for that, but I can't in 50 minutes go through all that. Why then don't we have proper facial growth? John Mew, The brightest orthodontist to ever live turned 92 last week in London, England, and this is what he has to say. I met him 30 years ago in March, and he's been the biggest mentor to me. And what he has to say is if you keep your teeth together lightly, your tongue to the palate, your lips together, breathe through your nose, you'll grow according to your genetic plan. If you don't, your jaws and face will fall down and back. There's not one person who has ever refuted this tropic premise. And John uses this slide here to show what happens to the face, and you see a kid who's 3 years of age is already having his chin fall back, and by age 7 you see him falling back more, and by age 50, look at how far back the face is. And what's happening is you see that the forehead slopes back to keep the chin forward, and therefore you keep the airway open. People have forward head posture, they tilt their forehead back, and that's how we all stay alive. No one knows anything about that, it's ignored completely. People don't understand that, but it happens all the time. It's routine. When you start understanding, you look at the person with this forehead that's sloped back like this, he looks like he's at Cape Canaveral watching a rocket go up, and he's just looking forward. That's just to stay alive. So what happens here then, when you realize this, no matter what class of malocclusion it is, everybody's got everything too far back. And so you see that as the face falls back, the soft palate falls back, the tongue falls back, and look at the profile of that face, and there are a zillion of you in this room who look like that. Now, I never put the profile norm on my face, nor that way I don't have to realize how unattractive I am. My wife married me anyway, so I'm not worried, but I don't want to really see how bad I really look relative to that norm. It's easy to delude myself. So the trouble is the faces continue to change throughout life. Then the next question is, can retraction change the growth of the face? Well, don't ask me. Let's look at the refereed literature. And this is a really common topic right here. The missing lateral incisor issue. Michael Jordan's missing one, Larry Bird is missing both, Oliver North is missing both of them. But we seem to have this problem about missing lateral incisors. So, from age 8 to age 12, this little boy in the refereed literature, out of the American Journal of Orthodontics, gets his maxilla expanded, which doesn't do anything to retract him at all. Notice how his mandible grows downward and forward, as we were taught in school. Then, he goes through the treatment to bring the cuspids forward. Well, if you believe that, that's what happens. I have oceanfront property in Omaha, Nebraska to sell you. Look at what really happens. The maxillary centrals are retracted, and look at what happens to the forward growth of the lower jaw. Now, I happen to believe that will cause the entire lower face to not grow forward. And I say that because I've been at this a long time, and I've got long-term records on patients. It's not a good thing. And I believe the refereed literature supports me on that. Here's out of a Plastic and Reconstructive Surgery journal, which says if you close the missing lateral spaces, you're more likely to make that patient have to have the Le Fort 1 advancement. In other words, you retract the maxilla and now make it so that they have to have the maxilla brought forward surgically. Makes a lot of sense, doesn't it? Avoiding 2 implants, and now we're going to cut your whole upper jaw away and bring it forward to fix your face and teeth and airway. Wow. All to avoid 2 implants. And here's a gentleman who had that done years ago. He's in his 50s, and out of the blue, he had a stroke. My point to you is this isn't out of the blue. You should be able to predict this. And you can look at his face with his slope-back forehead. He's not an NFL lineman weighing 350 pounds, and all those guys are going to die early. People, 80-pound Asian women can have this problem. They're not overweight, but if their faces are pulled back, they can. So where are we in the refereed literature with this whole thing? So a year and a half ago, almost 2 years, in January of a year and a half ago, the AAO finally had a meeting on this in Marco Island, Florida. So let's look at the literature, out of the refereed literature, some articles on what happens with retraction. Here's number 1. And you can read this. Number 2, large incisor retraction leads to narrowing of the upper airway. That's another one out of, this is a European journal. Extraction treatment using maximum anchorage reduces the airway. Number 4, this is Guilleminault from Stanford. He's talking about missing teeth and all. and how it affects the airway. And finally, one more here. You can read it. Involving premolar extraction and incisor retraction further reduces the airway, as does headgear, and is contraindicated. Those are 5 articles from the refereed literature. Any 10-year-old person with a cell phone can find those better than I can. So here I am at the sleep apnea conference in Marco Island, Florida, and notice it's a consensus and guidance. Now, I'm guessing that there's not one issue in this group that you would all have consensus on. And you're basically on this kind of you're kindred spirits. You have a lot of things that you would have consensus on, but no one would have consensus on everything. I've never seen consensus in anything in dentistry. Then the next slide that was up there during the whole thing was this one, which kind of makes me understand. Protecting the future of your specialty. Well, what's that all about? So here's Guilleminot, who's now passed away, and this is what he said. That's his direct quote. And he said you must stop taking out teeth, and you must treat much earlier. Everything he had to say was completely ignored because the final draft of the white paper they announced was written before the first speaker spoke. Here are some other speakers that were at that meeting, and this is what one of them said. And another, and this is his article right there that says, dental extractions in conjunction with orthodontic treatment have a negligible effect on the upper airway. Not one quoted any of the 5 articles I just showed to you earlier. I wonder about that, don't you? And then we have this 2 years ago. The UK says, no proof that braces work. So the German government, after a meta-analysis, decides not to pay for orthodontics. I can't argue. As a matter of fact, in reality, if you're going to have retraction, you're better off than if you'd had no treatment. Better off with no treatment than being retracted. So let's look at then the big issue is what really happens to patients. Here's a woman who had teeth taken out as a kid and sees me, and I'm going to reopen extraction spaces for her. And in the midst of this, we only open, she's going to get her ready for surgery. We open spaces only in the upper arch. After opening those spaces, just as you've seen here, this is the sleep report that she had done, signed by a physician, and this is what it says. Her sleep apnea is completely resolved with orthodontic therapy, despite the fact that she's 10 pounds heavier. Amazing, isn't it? That's amazing, to reopen spaces only in the maxilla, allowing the tongue to come up and out of her throat, and now she gets a sleep report saying she has no apnea. Which brings us to the next slide. I always like to put this in here, and I ask you, is there even one person in this room that thinks that retraction could not produce sleep apnea? Is there one person? Raise your hand. Anybody? Okay, I don't see any hands go up. I agree with you. So the next question is, how far can you safely retract? Does anybody know that? I don't. I've been reopening spaces for people for 31 years this month, and I don't know. If you don't know where safe becomes unsafe, then how can you, I like these words, because they mean a lot to me. I'm an Eagle Scout. Ethically and morally retract at all. Now think about that. So let's talk about what can we do to optimize facial and airway development in kids over age 10. So look at that little girl. Now some of you may have seen arches that are that crowded. And she lives in the Silicon Valley area, about 350 miles from my office in Los Angeles area. And she's already she snores and sleeps with her mouth open. Nobody had a sleep test done, but my bet is she did have sleep apnea earlier. She had tonsils and adenoids taken out. But her face is already back from the ideal norm already. And her airway is already very close to having in the high risk for sleep apnea right there. So what happens if we take more teeth out? I won't go into all the details, but we have ways of creating space and lining those teeth up without removing any. And of course, all of you were taught that that would cause gum recession, weren't you? Because I was taught that at the University of Minnesota. Here she is. She's got an overjet, and I've offered to do orthotropics, which would advance her jaws. She doesn't want to do it. I've offered to do double jaw surgery. They reject it. They're happy. please realize that she's been offered to have anything to get her teeth ideally aligned, but this is where she lands. And you look and say, is there gingival recession going on? No. And Brendan Stack, who passed away, one of the brightest men ever, some of you may know him, a mentor to me, and he stated this very emphatically. He's incisal guidance is one of the worst concepts foisted on the dental profession. I have to believe him after seeing pain go away from patients for 31 years for me reopening extraction spaces. As soon as I create a slight overjet, I know I'm going to get my hug. That's when the pain is going to go away. And how many people contact me regarding reopening spaces? Well, I woke up this morning to one from Melbourne, Australia, and one from China. It's like I don't wake up and without getting an email from somebody somewhere who's been retracted. And they have very long emails that are very emotional. So here she is later on. Notice she's got an open bite, and you're all worried about that. I'm not. Look at her teeth, and they're lined up. And there she is from the front. Here she is later. Show me the recession. And the fact is, I'm going to show you some articles out of the refereed literature in a moment. So here's another kind of a case to treat. This is a case we see all the time. This is a patient who's got a slightly class 2 relationship, see the end-on-end relationship. And those of you who are not orthodontists, I can tell you, I was taught to use a headgear to shove the upper teeth back. That is, since 1981, we've known that the teeth don't stick out, but we still teach headgear to shove them back anyway. And the other thing, when the kid doesn't wear the headgear, is you take out the upper bicuspid teeth and move the teeth back, camouflaging the fact that the lower jaw is back, which is really the problem. And that's the airway on that young man. Not very big for a guy who plays lineman on a football team. So what are we going to do? We're going to do something that is absolutely not the standard of care. We create space in the lower arch where no teeth are missing. We're going to slide the lower teeth forward. And once we do that, create the space, we could put implants there or put in temporary anchorage devices here and drag all the back teeth forward, which is what he chose to do. And you see the spaces I created. You see how I basically impacted the second molars in the ramus. Then we reversed all of that, moved the entire lower arch forward orthodontically, slid them forward. You can still see the temporary anchorage devices in there. There's no gingival recession, even though we've been taught that there would be. And his face, I think, looks very nice because we've not retracted him. And here he is on his 20th birthday with his grandmother and his sister, who was treated orthotropically and never wore braces to get that nice smile. And his airway goes from the left airway to the right airway, from high risk for sleep apnea to very low risk for sleep apnea. And you were taught that indeed there might be push the teeth off the bone support. Are you worried about the bone support on the lower right, on the right-hand side there, the labial aspect of those teeth, after I've basically moved his teeth forward that amount? Can you do this in an adult? Well, let's try. Look at that. Class 2, and he's had spaces closed by somebody else. He wakes gasping for air and choking. We sent him for a sleep test. And the bottom line is I open spaces in the lower arch where he is not missing any teeth. See, there he's got 2 bicuspids there. I've added room for another one. And his snoring went away. I don't have a sleep test done for him to prove it. So many people don't want to spend the money on the sleep test, and I understand that. We are using heart rate variability testing to try to document this in our practice now because we can't get people to do sleep tests. So here he is, ready for implants to add extra teeth in the lower arch. So the trouble is, if you go to peer review of these cases, that's what the peer review committee looks like when you start to move teeth forward, because everyone has been taught that moving teeth forward will cause teeth to be lost. It's okay to have people lose their lives, but we don't want to lose teeth. So how about this for eliminating the appliance? And many of you may make appliances for people who have sleep apnea. And this woman was wearing one. She had a home sleep test revealing mild to moderate apnea. She has a serious pain pattern with a deep bite, and she wants free of that. Her face is back from where it ought to be. We opened spaces for extra teeth. Her headaches are gone. Her snoring is gone. We're going to add bicuspid teeth here. can see that she's not missing any teeth, but we added teeth. There she's got implants in, and her snoring completely gone unless she's wearing retainers. I haven't seen her for a while, for several years, but she's happy. And bigger smile, broader smile. Again, peer review committee is not going to smile on that. For those of you who don't believe me on the whole thing about pushing the teeth forward, here's 7 references I'll be happy to give you from the refereed literature saying you can advance the teeth and not cause gum recession. So, after reopening spaces for people since 1989, having a woman literally force me to try to do it, I came up with what I believe is a new syndrome. It's called ERRS. And we're dealing with a syndrome, and this is off the internet. So, what is the syndrome? Extraction, retraction, regret syndrome. A constellation of aesthetic, functional, and emotional signs and symptoms caused by tongue space, airway reduction from orthodontic retraction, all of which are preventable. Now, I actually came up with this acronym because ERRS is like mistake, right? Errors. You caught that. You're a bright group. You did catch that. Thank you. So, and you laugh about it, but it's not funny. I laughed about it when I came up with it, but it's not funny. It's deadly. And the 2 women who contacted me from Melbourne, Australia and China this morning on the internet, it's not funny to them. And I have many people who will say to me, I have extraction, retraction, regret syndrome. And the aesthetic, functional, and emotional things are really important. You better understand the emotional when you treat these people. And the fact is, it's preventable because nobody has to retract. So here's a message on the cell phone that we get from a woman from Lakewood, Washington. Listen.
Hello, I'm looking for Dr. Hang. My name is Jessica. I live in Lakewood, Washington, and I am in desperate need for an ortho or somebody who can be guided by you or somebody like you to do a reversal of extractions. I was an idiot. I took out 4 teeth, and I loved my teeth. I just didn't like the forward jutting of my upper teeth, and now I look like an old lady, and I hate it, and I don't know what to do. And my ortho, I've been dealing with them for a long time, telling them that this is not going as it's going, and they think that there's nothing they can do, and then I've just been doing research of what I can when I found you. Please give me a call because I'm crying myself to sleep every night, and I don't know what to do. Thank you. Bye-bye.
In there and all of that, she said, I'm crying myself to sleep every night. So this is what she looks like with those teeth before she has them taken out. And you say, well, why would someone take out teeth? And I would say the same thing. And this is what she says to me when I get on the phone with her, and I've never met her. Unfortunately, she's not in a position to come and have me reopen the spaces. So that was her smile before anyone did anything. And here she is after the treatment. You see how narrow it is, being pulled back. And see, before on the left and after on the right. You decide if you think this is okay for you or your kid. And then how about when you look at the x-rays of the roots of the upper incisors after she's been retracted? And I believe that root resorption is a big issue in retracting like that. I haven't been retracting since the early 1980s, so I don't see it. I stopped removing teeth way back when. So let's get back to one of the patients that you saw earlier, and we're going to reopen spaces for her. And we did a long-distance consultation for her because she lives out of state. And these are her concerns, and she is not happy, and she also doesn't breathe well. And this is a great way to make friends with women. You tell them that the changes in your face were due to aging. How many women would like to hear that? I mean, you do this over a 2-year period, and the face changes dramatically, and you tell her she's aging. That's probably not a good thing to say to most women. So we reopen the spaces, put implants in, and we get them restored. And her husband thanks me for helping his wife smile for the first time in 5 years. There's her narrow smile on the left after we've reopened spaces. And there, you saw that earlier. I won't keep it up here too long. And there's the other thing she said. You have shown me that good people do exist. That's the kind of thing I like to hear. But why are we doing that? Why did she need the teeth out in the first place? That's my whole point, is to help you people understand that it's not necessary. Or how about this one who traveled from Boston to see me? Here she had her upper second bis taken out and retracted back. Mandible's trapped. She gets pain, breathing problems begin immediately. Of course, they're not related, according to the orthodontist who treated her. She awakens choking at least 7 times before hearing about us from a friend. Now notice, she is not an NFL linebacker weighing 300 pounds. And her airway is rather small, and her face is back, she's not unlike most of us. We reopen the spaces. Here, by the time she comes back, the spaces are already opening on their own. We then open the spaces up completely, and now look what we do in the lower arch. We open spaces where she's not even missing teeth, because we created an overjet by opening the upper spaces. But notice we haven't created any recession. She sleeps fine with no choking and no pain. Do you think there's a relationship between retraction and her breathing problem? So here she is. She gets restored in the upper arch, and she's happy. She finally gets restored in the lower arch, and you can see the whole thing here in her airway. Notice that the lower incisor to mandibular plane angle is 115 degrees, and we as orthodontists know, it's supposed to be 90 degrees. Go find me the science in the refereed literature that there's a long-term benefit from that. And I can tell you as a runner that everyone who wins the Boston Marathon, and I haven't won it yet, I've run it 10 times, but I haven't won it, I'm still trying. But the Kenyans are going to win it. And I can tell you right now that the Kenyans don't have lower incisors 90 degrees to the mandibular plane. They're out here like this, and their airways are unbelievable. Of course they win. And what about the bone level? Have I pushed the teeth off the bone level? And here I have improved the airway from here to here. Now, I'm not saying that it's 100% due to this. You could have a head positioning issue and change the airway. But I don't want to do anything that reduces tongue space or airway for any human being. And there her smile, which was gummy. As the teeth get pulled down and back, we've pushed them back up and forward, and she's happier, very happy. Happy enough to refer her sister to me from Las Vegas, and I straightened her teeth. Here she is 2 years post-treatment. I pushed everything back forward, and what about the recession? So again, if I go to the peer review committee, they may not like that. But I'll do that anytime. So let's go into the world of orthodontic surgery, jaw surgery, okay? That's something that you're all scared of. I have a patient in surgery as we speak right now. In her late 20s, she's having surgery right now in St. Louis, Missouri. She lives in Texas, and she wants to be rid of her sleep apnea. I've already gotten rid of her migraine pattern that she had all the time. How did I do it? I created an overjet. I opened 1.5 millimeters space between her upper cuspids and her first bicuspids, and her headaches, the chronic migraine she'd had most of her life went away. I created an open bite. I got rid of incisal guidance. I'm a heretic, but I have people who get out of pain. My wife hasn't had a migraine headache in 9 years after I did that for her. So let's look at what happens to a gentleman who is retracted. He's from New Jersey, and these are his pictures which he's provided to me. His name is Patrick Zwally. I'm happy to say that. No problem here. He's here to cure the world and wants to see this stuff end. So if you want to go online, Z-W-A-L-L-Y, Patrick Zwally. His whole face went down and back because he's a chronic mouth breather, and that's what happens, as you saw from John Mew's slides. And then, of course, he went to the orthodontist who saw that his teeth were crowded, and instead of having treatment just to align the teeth without removal of the teeth, he has teeth taken out, which is pretty much like arriving at the fire with a gasoline tanker rather than water. It only makes it worse, and so this is what he looks like when he comes to see me. Not very good. A molar-to-molar open bite. Severe breathing and pain pattern began and worsened over a decade. When he flew to California, he wouldn't even sit down. He was in such pain. He was in such pain he couldn't sit. He bothered me as roaming around my initial patient room because he was in such pain. And he admits that he's a suicide risk. As his dentist, physical therapist, and an oral surgeon in New Jersey say, he talks about it all the time. He's been in pain for so long. His jaws are back. Hello, he has no chin. This is what he says to me about a month before he's supposed to have surgery. This is on a Sunday night at 9:40, I believe it came in, which means it was 12:40 in the East Coast. He's so concerned that he can't even come out to see me. He's going to fly me in a private plane and pay me $25,000 to treat him in New Jersey. And I couldn't believe it. I could barely sleep that night, but I didn't answer him. I woke up the next morning, and here's this next email. He says, oh, that's kind of crazy. Maybe I could get somebody to drive me to California. I could sleep in the back seat. When he did have surgery, he drove from New Jersey to St. Louis to have the surgery. And here he is showing his surgery afterwards, and he's had an incision right here because at age 28 now, he has an artificial jaw joint because his joints were messed up completely. The discs are out of place, and there's no way to salvage that. But he's a happy man. Here he is 6 weeks post-surgery with a total joint replacement. And this is what he says: was going to commit suicide. He weighs 117 pounds now. He looks like he came out of Auschwitz. He was about 120 when he went into surgery. And so that was what he looked like when he was 19 years of age. 170 pounds, and he was a bodybuilder, could bench press 300 pounds. And that's what happened to him because of this whole thing and the pain. He goes into great detail about it. Now he's getting, I couldn't eat 6 eggs if I wanted to, but he's gaining his weight back. And here he is, and now he decides to become a dentist, and he's all over the internet trying to keep people from having this kind of treatment. You see his jaws have been brought forward, which is very nice that we have a surgeon who can do that. The trouble is, why do we do that? Why do we retract him in the first place? What's the point of that? And you can see the result. Here he shows the posture change. Look at those arms on him. Do you think those could bench press 300 pounds? Wow. And this is what he says. He went to Mike Mew, who owns the internet, John's son. That's where he found out about me. My body and jaw were in shambles. Every day was basically the equivalent of human torture. I didn't open my jaw, speak, or move my neck for 6 months before surgery. And this is what he says after that. Pain difference after surgery is dramatic. Even my worst day now is better than my best day before the surgery. I think I'm on the right path to hopefully a full recovery. It was truly a nightmare. They can say it better than I can. Back to this woman who you saw already. She's had teeth taken out, tongue is back in her airway, feels her throat is blocked. She's had 3 years and opens that much space with an ALF appliance. Nothing wrong with the ALF, but it's not meant for this, obviously. She has mild sleep apnea, and I'm going to reopen her extraction spaces, but I told her she's going to have surgery. And there's her airway to begin with, which is better than many of you in this room right now. And so we get some space right there in no time, and this is what she says right away in our orthodontic treatment. She has less tension in her sinuses. She starts to cry because she's had 2 millimeters of movement in a month versus 4 millimeters in 3 years of previous treatment. So we get her ready, fully ready for surgery, and this is what she says: I'm going to have the best Thanksgiving of my life. That's what she meant was she's going to have surgery. She's going to have both jaws sectioned away and move forward and open her airway. And you saw what she said afterwards. She made this little thing out of her walk. She put these stones on the sidewalk and took a picture of it after her morning walk 4 days post-surgery. And that's what she said. Then what she really said later on was even the best statement. And all these symptoms have gotten better for her. You can read them as well as I can. Feels calmer, no anxiety, and here she is. She can do rapid changes of hand position on the guitar she never could do before. I have a feeling that has to do with the sympathetic versus parasympathetic nervous system. Now she's in parasympathetic mode versus fight or flight all of her time. And then this is, we're getting ready to get her restored. She's got her implants in place. You recognize that. I would do the surgery 10 times to feel the way I do now. That was one of the out-of-the-blue comments. So let's look at a true emergency case then, okay? There are emergency orthodontic cases, and you're about to see one. So here's a gentleman, grew up in the Philippines. He's had upper floors extracted to camouflage the fact that he has no face. And what does he say to my wife, who's my treatment coordinator? This is a direct quote from him. All my insecurities relate to the fact that I have no chin. I walked into the room and I took one look at his face and I said, this man has sleep apnea. I knew it in a moment. I took his blood pressure and that was what it was. And he was on meds for that. And I said, has your cardiologist asked you if you snore? No. Has he suggested a sleep study? No. I looked at him square in the eye and I said, you need a sleep study. Like, men are hard to get to, you know that? They don't want to listen to this stuff because, well, you know, that's for other people. I won't be affected by that, right? Women, however, actually plug it in and listen. Well, I got to this guy. In 2 days he had a sleep study done, and this is the result of it. How many of you do sleep? Okay. Would you like to have an AHI of 53? Pretty bad, isn't it? And you desaturate to 65%. That's pretty much a recipe for a heart attack or stroke every night, and he goes to bed. So I viewed it as an emergency, and he's ready for surgery now. What are we going to do? Bill Hang, the guy who never extracts teeth. I never extract teeth. Decided to extract lower bicuspid teeth, and let's explain why. Let's show you why. Because the surgical treatment plan is this. He has no overjet. His lower incisors are way out here. I must bring them back to create an overjet because I want his lower jaw forward massively. So this is the surgical treatment plan that we do. We bring the lower 6 anterior teeth back surgically, which creates an overjet. We advance the mandible, we advance the maxilla. We bring his chin forward so he looks a little better too. And this is what he says 10 days post-surgery. This is an email. Hey, Dr. Hang, couldn't wait to tell you my blood pressure as of today is 127/78. 10 days post-surgery. Amazing. Woohoo, Bobby. In 10 days post-surgery, he's gone from here to here. Now, I don't pretend to know what that is. I'm just a tooth carpenter. I'm an orthodontist. I don't really understand all that crazy stuff, and I don't take credit for anything. I just, hey, wow, I'm learning on every patient. Here he is post-surgery, about 3 weeks post-surgery. Here he is 5 weeks later, got his energy back, getting vivid dreams, which he never had dreams. He's now getting REM sleep, which he didn't get. And you can see his airway went from better than many of you in the room right here. He had sleep apnea. But now, look, we brought those teeth back, brought everything forward. His airway opens up massively. And here he is when he's done. We leave the spaces. Who cares? I don't care about those spaces. He doesn't either. And he's 25 pounds lighter, healthier, eating, very happy guy. His chin is forward. And he gets married again. And this was his fiance came into the office with him, and she said to us, she said, I wouldn't have been interested. I saw pictures of him before the surgery. I wouldn't have been interested in him. So the point is, he basically is now a healthy guy, doesn't need the blood pressure meds anymore because his blood pressure went way down. So those of you doing mandibular advancement appliances, I want to wish you well. Here's a man who's worn one, and you can see he's been retracted, and he's in this end-on-end position, and that doesn't work anymore because his airway is horrible. So what are you going to do? Is it radical to do surgery for a man like this? Is it crazy that I have a 20-some-year-old woman in surgery as we speak right now, and yesterday had a friend of mine who's taken my course with me, his daughter from New Jersey had double jaw surgery, never had orthodontic. Well, she had orthodontics, but no teeth taken out. Is that crazy? Because she has no energy. They're doing a documentary film on it. So what I've given you today is really just an overview. If I taught anyone how to do anything, I've gone very fast. Sorry for that. 50 minutes, all you can do is an overview. So I hope I've made the point that airway is everything, and until you fix that, nothing else matters. What you guys are doing is terribly important. And if you integrate this into what you're doing, then you're really going to be elevating the health of all the people who come to you for care in an amazing way. But you need to develop your teams to do that. And I'm here to try to help you in any way I can. So I'm kind of a crazy man. I'm addicted to running. I've been running for 50 years. I'm addicted to building stone walls. I'm addicted to keeping my wife miserable. For 49 years, I've been successful at that. But when I go places, I see funny stuff. So here I am in the Albany airport. A year ago, coming back from seeing the leaves at our former place in Vermont. And here's this advertisement from this real estate agent in Saratoga Springs, New York. And here she says, if you'd chosen the right realtor, you'd be flying first class right now. And I looked at that sign and said to myself, if you'd chosen the right orthodontist, you wouldn't have a smudged up smile that looks like you got caught in an elevator door and probably wouldn't have sleep apnea. I didn't say it, I just thought it. I'm alive today because I don't say what I think, frequently. Do any of you like that? Yeah, don't say what you really think. But then I turn around, and no joke, this is from the Albany Medical Center. Look at this, a little girl, and urgent care and all that. And I look at this and say, this is an emergency orthodontic case, and you don't recognize this, but you need to. Her maxilla is falling out of her head. She has very poor restoral posture. She needs to have her maxillary anterior teeth move forward now. And please note, those are primary teeth. But nobody's prepared to do that in this profession. I'm part of the American Academy of Physiological Medicine and Dentistry. I'm on the board of that group. My wife's sitting back here, voice major, mezzo-soprano. I saved her from singing on Broadway. She understands this stuff. She's my treatment coordinator. She's on the board of the Foundation for Airway Health. We're trying to educate the public. We're going to have O2 Day. October 2nd is O2 Day. We'd like you to help us celebrate that. So, for more information, please go here. You've been a terribly attentive audience, and it's so nice to see your faces rather than you looking like a bunch of bank robbers. So, thank you very much. I appreciate you.